All right, what's up, everybody? How are you guys doing? Welcome to the very first stream on Study with Kennedy. It is me, Uche Kennedy. For those of you that have not seen me before, my name is Uche Kennedy. Welcome to the stream. It's the first stream for the year. It's the first stream for the year, and really my first communication with you guys in 2025. So congratulations on being one of the very first people I'm going to be communicating with in this year. I am incredibly excited to reach out to you guys one more time. How have you all been, USMLE students? I see some of your comments on some of the videos we have before. I have been incredibly busy since last year, going into, what do I call it? The end of last year and the beginning of last year. It has been crazy. It has been work. But I think we are going to have a little more free time now, and I'm here to answer all of your questions. So if you have any questions about the USMLE, if your questions are related to neuro, even better, USMLE Step 1 exams, USMLE Step 2 exams. I'm about to be your coach for the next hour or so. You can use me as you please right now, because this is a rare chance that you guys are going to be having. Okay? I think YouTube is pissed. YouTube is like, where did this guy go to? Did this guy just disappear into the moon? Did he travel to the sun or something? And maybe, just maybe, they've not informed everybody that we are live. YouTube is like, hey, who knows if you will even be live? Hey. And some of you have also not seen me on YouTube for a very long time. You guys, it is not for nothing. And I promise you, it will be worth it when you finally find out why Kennedy has been locked away in his chambers. I have been tied down. I have been working with students though, all this while. So I've been talking to students, helping students, and I have good news for you guys. One student wrote her exam recently and got back her results, and she scored fantastic on that result. And that was a student that had failed this exam twice, her exam twice. So I want to see all of you actually attack the USMLE. I don't know if you're going to be attacking it. We are not lions, but we are going to smash that exam completely, because we are going to know and understand exactly how to think. That is the goal. We are going to learn and understand exactly how to think. We are going to do some neuro, okay, you guys? We are going to change our scenes, and we are going to discuss some neuroanatomy, all right? Remember, if you have any questions about the USMLE at any point, feel free to put them in the chat, and I'm going to be responding to them. In today's video, we are going to look at ascending and descending tracts. I think this is like the fundamental part of neuroanatomy. This is where we start from when we discuss neuroanatomy, okay? We are going to look at the ascending and descending tracts. We will discuss the ascending and descending tracts, and we will look at disorders related to the ascending and descending tracts. We'll look at disorders related to these ascending and descending tracts. Now, whenever you study neuroanatomy, or really any of the subjects you're going to be studying, the goal is not just for you to memorize. The goal is for you to be able to recognize patterns, okay? And many times, a lot of the things we are going to be learning are going to be pattern based. We have two main types of tracts. Like I said, there are ascending tracts and descending tracts. Ascending tracts are going to be tracts that are going from the spinal cord to the brain. They are ascending. Your descending tracts will be tracts that are coming from the brain down to the spinal cord. Okay? They are descending. That's how we name them. So when we say it's an ascending tract or it's a descending tract, we just mean it's either going to the brain, ascending, or coming from the brain down to the spinal cord, descending tract. So if I asked you, what do you think your ascending tracts are going to be conveying? What are they carrying? They will be carrying sensory stimulus from the environment to the brain, right? That's what your ascending tracts are doing. They'll be gathering sensation. So many of your ascending tracts are going to be sensory tracts. They are taking sensations from the environment and they're sending it to the brain. What will your descending tracts be doing? Your descending tracts will be bringing information from the brain down to the rest of the body. So many times your descending tracts will be motor tracts. They are asking your body to do something. That's basically what the descending tracts are doing. They're asking your body to do something. So ascending tracts are generally sensory, descending tracts are generally motor. There are only a few ascending or descending tracts that they really want you to know on the USMLE. Now, one of the things you already know by now is that not every single thing you have studied in med school is relevant on the USMLE, okay? And our goal is going to be to focus only on what is relevant on your USMLE. Of your ascending tract, which is where we are going to begin, of your ascending tract, your spinothalamic tract will be important. Your dorsal column, and your dorsal column actually continues up on the brainstem as your medial lemniscal pathway. So the dorsal column medial lemniscal pathway is the second one we are going to consider. And the third one that is important is the spinocerebellar tract. Your spinocerebellar tract. These are the third important ascending tracts we are going to be considering. We'll look at them. For each of these tracts, you want to know their function. You want to know their level of decussation. And you want to know what happens if they are damaged. Well, technically, if you know their function, that means you know what is going to happen if they are damaged or if there's a lesion. Okay, these are the three most important things you want to know for each of the tracts. You want to know the function of the tract, you want to know the level of decussation of the tract, and you want to know what happens when there is a lesion to the tract. Before we jump into talking about the tract, I would like us to look at what we call a monosynaptic reflex arc. A monosynaptic reflex arc. Let's consider this as our spinal cord, okay? Let's take this here, right here, to be the spinal cord. The spinal cord has an anterior portion. Remember, we have an anterior portion. This right here, we call the ventral horn. And we have this posterior aspect we call the dorsal horn. Generally speaking, the ventral horn is sensory. Oh, did I say sensory? That's a mistake. The ventral horn is motor, and the dorsal horn is sensory. Okay, the dorsal horn is sensory, the ventral horn is motor. And right there in the middle of the spinal cord, we have the central canal or the spinal canal. The spinal canal, of course, contains CSF that is flowing up and down the spinal cord and into your ventricles and your brainstem and all of that. Somewhere here we have your dorsal column, but we'll come to that in a little bit. So what is the monosynaptic reflex arc? We'll draw our spinal cord again. That is a very fantabulous spinal cord. And we are going to assume that this is a muscle, for example. This is a muscle. When this muscle is activated or stimulated, this muscle is going to send information into the dorsal horn of the spinal cord. So this is a sensory nerve or sensory neuron. It sends information into the dorsal horn of the spinal cord, sensory information. And this message that is sent is transmitted back to the ventral horn with the help of interneurons. And it returns back to this muscle via the ventral horn. Okay? It returns back to this muscle via the ventral horn. Now, when you strike a tendon, for example, your knee jerk reflex maybe, or your elbow reflex, any of the reflexes that we can elicit, when you elicit a reflex, the information is sent straight into the spinal cord and straight out via the ventral horn. This arc of movement into the spinal cord and directly out of the spinal cord is called a monosynaptic reflex arc. And it is called monosynaptic because we have one synapse usually. The information gets into the spinal cord. Many times it even skips the interneurons and goes directly into the ventral horn nerve. This ventral horn nerve is what we call the lower motor neuron. The nerve that is coming from the spinal cord to your muscle. This nerve is the lower motor neuron. I hope that makes sense. So when you strike my patellar tendon, when you strike a person's patellar tendon, for example, the information is sent into the spinal cord. You don't think about it. It doesn't go to the brain. It just comes out and the knee or the leg moves in response, right? That's your knee jerk reflex. You strike the tendon, the information runs into the spinal cord, and it's out immediately through the ventral horn, and the patient executes the knee jerk reflex. I should actually put this patellar tendon on the sensory part. That's what we call the knee jerk reflex, or any of the reflexes you're going to be looking at. Okay? This pathway is called the monosynaptic reflex arc. Why is this important? Anytime you damage any of the nerves that are part of the monosynaptic reflex arc, the muscle will lose its tone. The integrity of the muscle tone, this is something you should remember. The integrity of the muscle tone depends on the status, I've actually quoted this wrong, of the monosynaptic reflex arc. This is not how I would usually quote this. The best way to quote this is to say the tone of a muscle depends on the integrity of a monosynaptic reflex arc. I think that's actually a better way to put it. The tone of the muscle depends on the integrity of the monosynaptic reflex arc. The tone of a muscle depends on the integrity of a monosynaptic reflex arc. Okay, so what that means is if you damage any of the components of the monosynaptic reflex arc, the muscle will lose its tone. If you damage any of the components of the monosynaptic reflex arc, the muscle will lose its tone. So whether we are talking about lower motor neuron lesions, which is what we are going to be talking about most of the time, damage to any of these parts of this monosynaptic reflex arc will result in loss of muscle tone. Now that we've gotten that out of the way, we are going to jump right in and begin looking at your ascending tracts. The ascending tracts go from the spinal cord to the brain. We have a nerve that is coming from a certain part of the body. We have a nerve that is coming from a certain part of the body into the spinal cord. We are going to start by looking at the spinothalamic tract. It comes into the spinal cord via the dorsal horn. It comes into the spinal cord via the dorsal horn. Now, right here, we have a synapse that occurs, but we don't want to bother too much with this. Before the nerve goes into the spinal cord, it kind of goes into this synapse right here. I don't know if we can really call it a synapse, but the nerve goes into the dorsal root ganglion. Okay, I don't want you guys to be bored with too many teeny details, because these details are not important for the USMLE. Right there, as we are going into the spinal cord on the dorsal part, there is a dorsal root ganglion. Whether you call it the dorsal root ganglion or you're thinking of the dorsal horn, they are all performing exactly the same function. Okay, this type of neuron is called a bipolar neuron. The head of the neuron is in the dorsal root ganglion. We have one arm of the neuron coming from your muscle, for example, and we have one arm going into the spinal cord. This nerve is going to synapse somewhere in the spinal cord. It's going to synapse. We have a lot of synapses, like the substantia gelatinosa, nucleus proprius. Again, nobody cares about this on the USMLE. What I want you to remember, however, because I've seen some NBME questions, I need you to put this to mind, that substantia gelatinosa which is a synapse for your spinothalamic tract, okay? The function of the substantia gelatinosa is pain and temperature. This is a question I saw on an NBME a while back. The function of substantia gelatinosa, which is one of the synapses or one of the nuclei you're going to have within the spinal cord, is pain and temperature. Now, when this nerve comes into the spinal cord, it's going to cross over to the opposite side. So if this nerve is coming from the right-hand side, it's going to cross over to the left-hand side. On this left-hand side, this is the spinothalamic tract we are dealing with now. We have two portions. We have this part, which is anterior, and we have this portion, which is more lateral. What does that mean? We have two types of spinothalamic tracts. We have the anterior spinothalamic tract and the lateral spinothalamic tract. The anterior spinothalamic tract and the lateral spinothalamic tract. We are not trying to differentiate them here. We don't care about differentiating them. Just know that the spinothalamic tract comes into the spinal cord, it crosses over to the opposite side, meaning that the spinothalamic tract from the right hand side ends up on the left hand side, and then it begins to ascend to the brain. It begins to ascend to the brain. This spinothalamic tract is going to travel all the way to the thalamus. It's going to travel all the way to the thalamus, and that's your thalamus. The thalamus is an egg-shaped structure. And on the side of the thalamus, we have this nucleus that we call VPL, the ventro-posterolateral nucleus of the thalamus. The ventro-posterolateral nucleus of the thalamus. Your spinothalamic tract is going to synapse in the ventro-posterolateral nucleus of the thalamus, and then another set of fiber is going to continue all the way to the brain. Look at this pattern. If you recognize this pattern, that means you already know exactly all you need to know about the traveling and the pathway of the spinothalamic tract. It arises somewhere in the body, like we can see here. It travels into the spinal cord. It crosses over to the other side, meaning that the spinothalamic tract coming from your right hand actually ends up on the left side of the spinal cord. The spinothalamic tract coming from the right leg ends up on the left side of the spinal cord. And then it travels all the way to the thalamus and synapses in the ventro-posterolateral nucleus of the thalamus. And from the ventro-posterolateral nucleus of the thalamus, it's going to travel again via the internal capsule to the brain, to the sensory areas in the brain. It's going to travel via the internal capsule to the sensory areas of the brain. If you're trying to be specific, around area 3, 2, 1. Don't worry about the classification. That's Brodmann classification, not very important for the USMLE. to the sensory areas of the brain. I told you earlier that with these spinothalamic tract, for example, you want to know the function of the tract. There are two types of spinothalamic tract. We saw the anterior spinothalamic tract, and the function of the anterior spinothalamic tract is crude touch and pressure. Crude touch and pressure. The function of the lateral spinothalamic tract is pain and temperature. Okay, the function of the anterior spinothalamic tract is crude touch and pressure. The function of the lateral spinothalamic tract is pain and temperature sensation. So if you feel pain, someone pinches you and you feel pain, it is your spinothalamic tract that carries that information to the brain, specifically your lateral spinothalamic tract. And when we are talking crude touch, like rough, crude touch, that would be the function of the anterior spinothalamic tract. The substantia gelatinosa is one of the synapses you have for the spinothalamic tract within the spinal cord. The function of substantia gelatinosa is pain and temperature. It's one of those things that you don't really need to bother about the detail of it, but just have it at the back of your mind, because I have seen an NBME question on that before. Now, what about the level of decussation? When we say level of decussation, we really mean where it crossed over, okay? The level of decussation is the point at which the tract crossed over to the other side. Your spinothalamic tract, if you noticed, crossed over at around the level of the spinal cord. So it came into the spinal cord and it went over to the other side, like you can see here, right? The spinothalamic tract comes in and it crosses immediately at the level of the spinal cord. If we want to be a little more technical, it crosses at around 1 to 2 spinal segments within the spinal cord, but you don't have to worry about that. Just remember that the spinothalamic tract crosses at the level of the spinal cord, and then it ascends in the spinal cord all the way to the ventral posterolateral nucleus of the thalamus via the posterior limb of the internal capsule. So it's your internal capsule. You may want to remember specifically that it's the posterior limb of the internal capsule, and then it ends up in the brain, your cerebral hemispheres up there. The level of decussation, therefore, is the spinal cord. And then some of you may be asking, Kennedy, why is it important for me to know the level of decussation? It's important to know the level of decussation because if you know the level of decussation, you know how injuries to this tract are going to behave. So if I tell you that someone had, someone had a stroke, a right-sided stroke in their brain, which part of their body will suffer a loss in pain and temperature? You can easily tell me it's going to be the left side of the body, because you know that your spinothalamic tract crossed over at the level of the spinal cord. So anything that happens to the spinothalamic tract is always going to be contralateral. So when we talk about the spinothalamic tract, now we can talk about lesion. If there is damage to the spinothalamic tract anywhere at all in the body, it will always be contralateral. So bear that in mind. Lesions to the spinothalamic tract are always contralateral. They are always contralateral. Why are they always contralateral? They are always contralateral because the spinothalamic tract crossed over right in the spinal cord. So whether it is a brainstem injury or a cerebral injury, the spinothalamic tract already crossed over. If you damage it on the right-hand side in your brain or in your brainstem, that right-hand sided spinothalamic tract is actually coming from the left-hand side. So you lose pain and temperature sensation on the left side. I hope that makes sense. Okay. Now, the next tract we are going to look at is the dorsal column. The dorsal column. The function of the dorsal column is modern. It's more fine kind of function, okay? Vibration, for example. Fine touch. If you remember, we had mentioned earlier that the function of the anterior spinothalamic tract is crude touch. The function of the dorsal column is vibration, fine touch, 2-point discrimination. Or tactile discrimination, anyhow you want to put it. Your ability to distinguish between two touch points on your body at the same time. 2-point discrimination or tactile discrimination, that is also a function of the dorsal column. One of the other functions of the dorsal column is what we call stereognosis. Stereognosis. What is stereognosis? When I put an object in your hand, for example, if you closed your eyes and I put a pen in your hand, you will be able to tell me just by touching it that this is a pen. If I put a key in your hand, you'll be able to tell me just by feeling it that yes, Kennedy, that is a key. How are you able to recognize objects just by feeling them? That is called stereognosis, and that is a function of the dorsal column. You want to remember that. So it does all of those things, okay? Vibration, fine touch, 2-point discrimination, stereognosis, and I almost forgot one, proprioception. Proprioception. In some books, proprioception will be described as position sense. Again, when you close your eyes and I ask you to stand, even if you're closing your eyes, you can kind of appreciate, you have spatial understanding of your position in space. You're not going to fall just because you closed your eyes. That is because you can feel your environment. You have a sense of where your positioning is. If I lift up your thumb or your pinky, you'll be able to tell me, okay, that is my thumb. That is my second finger. That is my third finger. That is because you have proprioception, position sense. And all of that is a function of the dorsal column. Now, with the dorsal column, we have fibers that again arise from a part of the body. We are going to draw this a little more central. We have fibers that arise from a portion of the body, let's say the lower limb. Fibers from the lower limbs, let's say the legs, they come into the spinal cord, just like your spinal column, your spinothalamic tract did. They come into the spinal cord and they end up in the dorsal column area, right here. These fibers end up in the dorsal column. Now, the fibers that are coming from your leg are going to go all the way in, and then they begin to travel up to the brain on the same side. Notice that these fibers did not cross over. They came into the spinal cord, they occupied the dorsal column area behind, right there, and they began ascending to the brain. Now, if you want to be a little more detailed, when the fibers of your dorsal column enter the spinal cord, they actually synapse on a nucleus. Remember we talked about substantia gelatinosa in relation to pain and temperature with the spinothalamic tract. With the dorsal column tract, we have what we call the nucleus proprius. And based on the name, I'm sure you can already tell me that the function of nucleus proprius is what? Proprioception. The function of your nucleus proprius is proprioception. The function of the nucleus proprius is proprioception. So when these fibers come in, these dorsal column fibers, they synapse in the nucleus proprius and they occupy the dorsal column area and begin to ascend to the brain. On the same side, they did not cross over. Now, when they get to the base of the brainstem, right there, at the base of the brainstem, these fibers are going to synapse for the first time in one of the nuclei that we have there. The fibers of the dorsal column that come from the legs are called fasciculus gracilis. The fibers that come from the lower limb are called fasciculus gracilis. They come from the legs. They are called fasciculus because they are arranged in form of a fascicle. They are roundish like that. They are arranged like a fascicle. Fasciculus gracilis. And they synapse at the base of the medulla in what we call the nucleus gracilis. These are the fibers from the lower limb. The fibers from the upper limb come in as well. Fibers from the upper limb come into the spinal cord. I need me another spinal cord right here. Let's make another spinal cord. I cannot make it line up, can I? Okay, we have to try to make our drawing work somehow. Okay, again, we'll divide our dorsal column right here. And we'll take a different color for these fibers. The fibers that come from the upper limb come into the spinal cord like that. Not here. Kennedy cannot draw today. You guys, pardon me. The fibers from the upper limb come into the spinal cord like that. And they don't cross over the fibers that were already there. One of the things you would like to bear in mind is the organization of these fibers, the arrangement of these fibers, okay? So they come in and they sit by the side of the fibers from the lower limb, right there. And they travel without interference into their own nucleus at the base of the medulla. This is the base of the medulla right there. The synapse there. This nucleus, where the synapse at the base of the medulla, is called nucleus cuneatus. This is called nucleus cuneatus because the fibers coming from the upper limb are called fasciculus cuneatus. So we have two of them. The two fibers, fasciculus cuneatus and fasciculus gracilis, from the lower limb and the upper limb together make up what we call the dorsal column. So the dorsal column consists of two fibers, fibers from the lower limb, fasciculus gracilis, and fibers from the upper limb, fasciculus cuneatus. These two fibers ascend, and when they get to the base of the medulla, they synapse in what we know as the nucleus gracilis and the nucleus cuneatus. After this synapse has occurred, these two fibers are then going to cross over, dissociate. They cross over to the other side. They cross over to the other side. Fibers coming from nucleus cuneatus and nucleus gracilis cross over to the other side. So if I asked you, what is the level of decussation for the dorsal column-medial lemniscal pathway? The level of decussation is at the base of the medulla. The level of decussation is at the base of the medulla. I hope that makes sense. The dorsal column pathway came into the spinal cord, traveled on the same side in the spinal cord up to the base of the medulla. At the base of the medulla, they decussated. They crossed over to the other side. So once again, if it's coming from the right hand side over here, at the base of the medulla, it crosses over to the left hand side. This is the most crucial thing you want to remember about the dorsal column pathway. These fibers that cross over are going to continue traveling, and ultimately they would also come to that nucleus where your spinothalamic tract came to previously. Do you remember what the nucleus was called? VPL. What did that stand for? The ventro-posterolateral nucleus of the thalamus. They will synapse in the ventro-posterolateral nucleus of the thalamus, and then another fiber will leave the ventro-posterolateral nucleus of the thalamus travel through the posterior limb of the internal capsule, just like before. The posterior limb of the internal capsule and end up in the sensory areas of the brain. Area 3, 2, 1. Somatosensory cortex. This basically is your dorsal column. What is the implication of what we have just described? If you understand this, you'll be able to break down all those neuro questions, localize the lesion. They would make a lot of sense. So let's look at what and why this is important. If you have a spinal cord injury, if a person has a spinal cord injury, a lesion within the spinal cord, they are going to lose function on the ipsilateral side. So let's talk about lesions here. Dorsal column lesions. What happens when there is a lesion to the dorsal column? The first thing you want to remember is that lesions within the spinal cord lesions within the spinal cord are always ipsilateral. Lesions within the spinal cord are always ipsilateral. So if you damage this, if someone has an injury to the spinal cord and you damage the dorsal column, they are going to have an ipsilateral loss of vibration, loss of proprioception, ipsilateral loss of fine touch, 2-point discrimination, ipsilateral astereognosis, and we'll talk about that in a little bit. But what if someone has a lesion within the brain stem? What if someone has a lesion within the brain stem or above the spinal cord in general? Now, lesions within the brain stem or above the spinal cord are always contralateral. Lesions above the spinal cord are always contralateral, right? Because if you damage your dorsal column in the brain stem somewhere here, even if this is on the left hand side, this dorsal column tract is actually coming from the right hand side over here. Do you see that? If you damage the dorsal column in the brain stem, even though you're damaging it here, for example, on the left hand side, that tract actually originated on the right hand side. So lesions above the spinal cord. And why did that happen? Because of the decussation that happened at the level of the medulla. Sometimes this is called the great motor decussation. Sorry, the great sensory decussation, not motor. It's called the great sensory decussation. And then some of you may have wondered, why do we call the dorsal column pathway dorsal column-medial lemniscal pathway? It's because, like I mentioned earlier, they occupy the dorsal column of the spinal cord. So we call them dorsal column. When these fibers cross over, remember they were shaped like fascicles, they were round like that, fascicles. So we call them fasciculus gracilis, fasciculus cuneatus. When they get to the base of the medulla and decussate, the shape changes. They become more, maybe pyramidal is the word. They become shaped more rectangular like that. That's how they organize themselves. So we call them lemnisci. They organize themselves like a lemniscus. Okay, so it's called dorsal column-medial lemniscus or lemniscal pathway. That's where the name comes from. So they ascend and they end up in the sensory portion of the brain once again. You want to remember that. Now, how about the effect? If something goes wrong with the dorsal column, how does the patient present. If there's something wrong with the dorsal column, you will have loss of vibration. There will be loss of vibratory sensation if something goes wrong with the dorsal column. There will be loss of 2-point discrimination. There will be loss of 2-point discrimination. There will be astereognosis. There will be astereognosis. What does astereognosis mean? It means that when you put a key in the patient's hand or known objects that the patient is familiar with, the patient will not be able to recognize them with his eyes closed. That is what astereognosis is. When you close your eyes and I put an object in your hand, a phone for example, the patient cannot recognize that that is a phone. So there will be loss of astereognosis. There will be loss of 2-point discrimination. When you poke the patient or touch the patient with 2 objects simultaneously, the patient may not be able to differentiate them within a particular distance. You want to remember that. That is what happens when there is dorsal column lesion. Loss of vibration, loss of proprioception, loss of 2-point or tactile discrimination, and astereognosis. Okay, these are the findings you will have when you damage your dorsal column. Finally, we have, or for the ascending tracts, we have your spinocerebellar tracts. Your spinocerebellar tract. The spinocerebellar tract. If you notice, the name literally says spinocerebellar. That means that this tract is going from the spinal cord to the cerebellum. We don't need to discuss too much on these tracts. Just remember that with your spinocerebellar tracts, they just come into the spinal cord, occupy the lateral part or the posterior part, right? Sorry, the posterior part or the anterior part, really, doesn't matter. They occupy either the posterior part or the anterior part of your spinal cord. So we'll say posterior spinocerebellar tract, anterior spinocerebellar tract, okay? So there are actually 2 of them, anterior spinocerebellar tract and posterior spinocerebellar tract. What do you think is the function of the spinocerebellar tract? The function of the spinocerebellar tract is balance. It's basically the function of the cerebellum, okay? Balance, coordination. So I like to think of it as balance for the most part. These fibers come into the spinal cord and they just ascend on the same side to the cerebellum. They come into the spinal cord and they ascend on the same side to the cerebellum. That's all. On the same side. So whenever you damage these fibers, it doesn't matter whether you damage them in the brainstem, you damage them in the spinal cord, they did not cross over. Lesions to the spinocerebellar tract are always ipsilateral. Lesions to the spinocerebellar tract are always ipsilateral. You want to remember that. Lesions to the spinocerebellar tract are always ipsilateral. I just remembered something I might have missed when we talked about the dorsal column, medial lemniscal pathway. When there is damage to the dorsal column pathway, you want to remember that these people are going to have positive Romberg sign. This is what you get when you do this off the fly. But I prefer to teach these lectures off the fly like this because it allows you actually hear my thought process, and it allows me teach them to you the way I think of them in my mind. That's the goal here, right? Positive Romberg sign. What is positive Romberg sign? On your vignette, they are going to tell you that when the patient is asked to close his eyes, he fell or he was going to fall if not for the nurse that caught him or something of that nature. They will describe a patient that when asked to close his eyes cannot appreciate his position, spatial space. Okay, so when you close your eye, you still have a sense of your environment because your dorsal column is working. But in patients that have dorsal column damage, when you ask them to close their eyes, they cannot appreciate their position in space, and so these patients will tend to fall. That is what we call positive Romberg sign. Okay, that is what we call positive Romberg sign. I've seen them describe it a couple times in some vignettes, so you want to remember that. Now, back to your spinocerebellar tract. Lesions of the spinocerebellar tract are always ipsilateral. Lesions to the spinocerebellar tract are always ipsilateral. Ipsilateral ataxia. There will often be ataxia. Okay, ipsilateral ataxia. You want to remember that. These are the ascending tracts that are important for the USMLE. They want you to know the spinothalamic tract. They want you to know the spinocerebellar tract. They want you to know the dorsal column-medial lemniscal pathway. The other tract that is important is your descending tract. The descending tract. For the USMLE, the only descending tract we are interested in is the corticospinal tract. The only descending tract we are interested in on the USMLE is the corticospinal tract. The corticospinal tract arises in really 3 areas of your brain. It starts on area 4. Some of the fibers arise on area 4, which is the primary motor cortex. Okay, you don't need to know the numbers and exactly what they do, but if you know it, you'll be happy. The primary motor cortex, area 4, area 6, your secondary motor cortex, and I think on your area 3, 2, 1, your sensory cortex. Okay, your spinothalamic tract arises from these 3 areas. On area 4, we have large nuclei or large cells we call the giant cells of Betz. The giant cells of Betz. You don't need to worry about those cells, but those are cells that contribute immensely to the corticospinal tract. It's going to descend, pass through the posterior limb. Notice that everything so far is going through the posterior limb of the internal capsule. This is important when you look at certain strokes that can occur. That is why when there is a stroke affecting the internal capsule, you have a person that gets paralysis, for example. That is because your corticospinal tract travels through the posterior limb of the internal capsule. Okay, we are not going to go into too much detail about its pathway and all of that, but it travels down into the brainstem. Now, in the brainstem, when the corticospinal tract gets to the pons, I'm going to denote some of the levels here. You don't need to stress too much about the details, but I want you to understand why some of the symptoms present the way they are and why some of the names are the way they are. When this tract gets to the pons, you would remember that in your pons, we have pontine nucleus or nuclei on the anterior surface of the pons. We have a lot of pontine nuclei. These pontine nuclei do not allow the corticospinal tract to travel smoothly through the pons. So what happens? The corticospinal tract splits, it breaks open, it breaks apart, it spreads, and you have those fibers traveling all over the place like that. That's basically what happens to the corticospinal tract. at the level of the pons, and this is because of the pontine nuclei. Those nuclei on the surface, in the surface of the pons, not necessarily in the surface, the nuclei within the pons, especially on the anterior aspect, they cause the nerves to spread. And then when it gets to the medulla, at the level of the medulla, they've gone past the pons now successfully. They come back together. However, as they come back together, they come back like that. Look at that. The fibers begin to gather again. The fibers begin to gather again. As they gather again, while they arrive at the medulla, they form this pyramid-shaped structure coming into the spinal cord. They form this pyramidal shape going across the medulla into the spinal cord. This is why the corticospinal tract is also known as the pyramidal tract. So you hear them say pyramidal tract, corticospinal tract, exactly the same thing. Pyramidal tract, corticospinal tract, however it is named, this is the reason why. Okay, what I'm trying to show you here is why some things are the way they are. Some of these fibers will continue directly. Some of them are going to move apart, go into the lateral portion of the spinal cord. Now, within the spinal cord, as usual, we have an anterior part of the spinal cord where your anterior spinothalamic tract, for example, was. Your lateral spinothalamic tract was on one side. We had our posterior spinocerebellar tract, anterior spinocerebellar tract. The corticospinal tract occupies the lateral aspect of the spinal cord, right here. The corticospinal tract occupies the lateral aspect of the spinal cord. Of course, on both sides, it occupies the lateral aspect of the spinal cord, right there. A few fibers of the corticospinal tract will end up in the anterior portion of the spinal cord, somewhere here. A few fibers forming the anterior corticospinal tract, but nobody cares about the anterior corticospinal tract. Whenever we talk about the corticospinal tract, I want you to only remember that this corticospinal tract occupies the lateral aspect of the spinal cord, like that. If you remember that, that would be great. These nerves are going to travel down into the lateral portion of the spinal cord. Now, if it was this simple, we would have been very happy. But I'm going to tell you something that happens. At the base of the medulla, you see, as I keep talking about it myself, I'm skipping some of the information. At the base of the medulla, as these nerves and these fibers collect together, they cross over to the other side. As they collect together at the base of the medulla, they cross over to the other side and end up on this part of the spinal cord. So we have spinothalamic tracts coming from, let's say, the left side of the brain over here. Spinothalamic tracts coming from the left side of the brain up here. And then they got to the base of the medulla and they have crossed over now to the right hand side of the spinal cord. So they started on the left at the brain. They were on the left in the brain stem, but in the spinal cord, they are on the right hand side. Why is that important? As we would see later, when there is a damage to the corticospinal tract above the spinal cord, it is going to be contralateral. When there is a damage within the spinal cord, it will be ipsilateral. We'll talk about that in a moment. What is the function of the corticospinal tract? What is the function of the corticospinal tract? The function of the corticospinal tract is rapid, scaled movement. Rapid, scaled movement. The function of the corticospinal tract is rapid, skilled movement. Skilled movement, like buttoning a shirt. Buttoning a shirt is a skilled movement. For example, if you play the piano, you notice that when you start learning how to play the piano, initially, the fingers don't move like you want them to, right? Your fingers don't move across the keys the way you want. And then you practice and you practice, and then you build what we call muscle memory. But basically, you have a wiring of your corticospinal tract to understand those motions. That's a skilled movement. Your corticospinal tract is helping you do that. The corticospinal tract does not mature until a person is around 2.5 years old. Meaning that children, even if you try to teach them, very young children, they will not be able to button their shirt properly. Maybe if they fiddle with it for a while, they might accidentally get it, but they don't quite know how to button a shirt because that is a skilled movement. So the function of the corticospinal tract is rapid, skilled movement. The second thing you want to remember is that the corticospinal tract is also known as the pyramidal tract. The corticospinal tract is also known as the pyramidal tract. Number 3, the corticospinal tract is also called upper motor neuron. The corticospinal tract is also called upper motor neuron. When we talked about the monosynaptic reflex arc, we saw the lower motor neuron coming from the anterior horn of the spinal cord. The upper motor neuron comes from the brain, from the cerebral hemispheres, all the way to the spinal cord. Corticospinal tract, from the cortex to the spinal cord. And what does it do? It interacts or helps modulate the function of the lower motor neuron. The function of the corticospinal tract is to modulate or modify the activity of the lower motor neuron. The function of your upper motor neuron is to help modulate the activity of the lower motor neuron. Why is that important? Remember when we talked about your lower motor neuron, we talked about the monosynaptic reflex arc. I stimulate your patellar tendon and your leg moves reflexively. If we didn't have any communication with the brain, if I stimulate your patellar tendon, your leg will just fling far away because there's nobody to modify it. Okay? The corticospinal tract is what says, calm down with the reflex. Calm down with the reflex. We don't want too much reflex. That's basically what it is. The monosynaptic reflex arc says, reflex, 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 reflex. Everything should be reflex. Everything should be reflex. Jerk. The upper motor neuron says, okay, calm down a little bit, not too much of the reflex. That's basically the relationship that they have going on here. Why is that important? Because when you have damage to the upper motor neuron, what we call upper motor neuron lesion. When we say upper motor neuron lesion, we are really talking about damage to your corticospinal tract. Okay? When we say upper motor neuron lesion, we are really saying damage to the corticospinal tract. What will happen if that is the case? There's nobody to tell your lower motor neuron and your monosynaptic reflex arc to calm down. So we are going to get hyperreflexia. The reflexes are excessive. The reflexes are excessive. Hyperreflexia. Because we have damaged the upper motor neuron whose function it was to tell your lower motor neuron, okay, calm down with the reflex. The other thing your lower motor neuron did was maintain the tone of a muscle. If you remember, we mentioned that the tone of a muscle depends on the integrity of the monosynaptic reflex arc. So your monosynaptic reflex arc wants to do tone, 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 excessive tone. Your upper motor neuron lesion says, okay, this is enough tone. This is as much tone as we want. So when you damage the upper motor neuron now, there is nobody to say that's enough tone. You just have excess tone. That is what we call hypertonia. So in upper motor neuron lesions, we have hyperreflexia, we have hypertonia as well. The other feature you're going to find is positive Babinski sign. Positive Babinski sign in upper motor neuron lesion. Essentially, when the bottom of the foot is stroked, when you stroke the bottom of the foot like that, you're going to elicit extension of the big toe and fanning out of the fingers. Okay, that's what positive Babinski is. Extension of the big toe, or of the toe, not like this, a small toe, and fanning out of the digits. Extension of the toe and fanning out of the digits. This is what positive Babinski sign is. Okay, the patient will also have this hyperreflectic jerky movement, what we call spastic paresis. They have spastic paresis. Spastic paresis. Another thing you're going to find in patients with upper motor neuron lesion is that because there is excessive tone on the muscle, if you try to pull their hands apart like that, you try to ask the patient to put his hands together and you try to separate their hand, it's going to be very difficult. But when you pull it apart and you let go, the hands suddenly come back together. You pull it apart and you let go, and it moves excessively that way. In a normal person, that doesn't happen, right? If you pull my hand apart and you let go, my hands will come back together like that. But in these patients, when you pull their hand apart against resistance and you let go, their hands swing over. That is called clasp knife reflex. Clasp knife reflex. They have positive clasp knife reflex. Some books are going to call it positive clasp knife spasticity, for example. These are going to be seen in upper motor neuron lesion, or in corticospinal tract lesion, or in pyramidal tract lesion. Whatever name they use, it's the same thing. These patients are going to have weakness, of course. They have weakness. And they have atrophy of disuse. They have atrophy of disuse. We are going to talk about lower motor neuron signs just now. They have atrophy of disuse. What is atrophy of disuse? Remember, we just said they have hypertonia. They have increased tone of the muscle. But if you don't use it, you lose it. You lose it when you remove the nerve stimulation of a muscle. When you remove the nerve or endocrine stimulation of a muscle, the muscle is going to undergo atrophy. It's like if you don't go to the gym, or if you don't go to the gym, then you're just not going to notice any difference. But for persons that go to the gym and have big muscles, when they stop going to the gym, nothing is wrong with them. Their muscles just begin to reduce in size, right? Because when you remove the stimulus to a muscle, eventually it's going to undergo atrophy. So people with upper motor neuron eventually develop atrophy, but this is atrophy of disuse. Now that we've talked about upper motor neuron, let's contrast it with lower motor neuron damage before we start looking at some spinal cord lesions. So very quickly, we'll look at lower motor neuron lesion. Remember, your lower motor neuron was the nerve that came. Why is my spinal cord looking like this? Your lower motor neuron was the nerve that came out of the anterior horn of the spinal cord. The nerve that came out of the anterior horn of the spinal cord. This is your lower motor neuron. Okay? That is your lower motor neuron. This is the nerve that innervates the muscle. It is part of the monosynaptic reflex arc. You may remember, the lower motor neuron is an essential part of the monosynaptic reflex arc. So when you damage the lower motor neuron, what have you done? You have damaged the monosynaptic reflex arc. We stated earlier that the integrity, or not the integrity, the tone, the tone of a muscle depends on the integrity of the monosynaptic reflex arc. The tone of a muscle depends on the integrity of a monosynaptic reflex arc. What does that mean? If you damage this lower motor neuron, you have damaged or destroyed the integrity of the monosynaptic reflex arc. So the muscle tone will suffer. When you damage the lower motor neuron, you disrupt the integrity of the monosynaptic reflex arc, and the muscle tone will suffer. So these patients here will have hypotonia. They lose muscle tone. Of course, they are going to become weak. They will have weakness. They will have atrophy. They don't have any innervation for their muscles at all, so they are going to have atrophy of the muscle. What happens to those reflexes? The monosynaptic reflex arc, its function was reflex. Well, what do you think is going to happen to the reflex now that we've damaged the lower motor neuron? There will be areflexia. Areflexia or hyporeflexia. Basically, there is no reflex. That's what you want to know. Then there is an interesting concept that we say all the time, very few people understand the meaning, and it's fasciculations. When you cut an electric wire, let's say there's a cable, a power cable that runs across, I don't know, a town or a city or whatever, and that power cable cuts and falls to the ground. It is no longer supplying electricity to the neighborhoods downstream, wherever it was supposed to be going. But there is still power in the cable, right? You cut it, so this was the cable. We cut the cable here. The power was coming this way to supply this house over here. Now, there is no power here because we've cut the table. We've cut the cable over here. But we still have power on this part of the cable. That is what we mean. That's what happens when we damage the lower motor neuron. You no longer supply the muscle downstream, but you still have power in the proximal part of the neuron. From time to time, some of this electrical current is going to stimulate the muscles. It's not going to be enough to stimulate the entire muscle, but it's going to be able to stimulate a few fibers of the muscle. This will cause them to twitch. Okay? So imagine I damage my nerve, my whole muscle is weak, but there are tiny currents still acting on a little bit of the muscle, causing little twitching to be seen within these small muscle groups. This is what we call fasciculation. That twitching as a result of the little currents firing is what we refer to as fasciculation, and it is seen in lower motor neuron lesions. Now, because there's zero innervation to the muscle is going to become completely flaccid. So we are going to have flaccid paralysis. How do you spell flaccid? Is it double C? I think so. We are going to have flaccid paralysis. The muscle just becomes bleh. It's dead, right? There's flaccid paralysis. Think of a patient with polio. Have you seen patients with polio? Right? Patients with polio cannot walk. Their muscles are all shrunken. They look very skinny, dried up, right? Because all the muscles have undergone atrophy. Compare that to a patient on a wheelchair that had a motor accident and damaged their spinal cord, for example. You've seen people with spinal cord injury. They also cannot walk, but many times they look completely normal. They look bulky in some cases if they were bulky before, and it takes a very long time sitting on the wheelchair before you start noticing some muscle atrophy occurring in those people. So people with polio, for example, have lower motor neuron lesion, whereas people with upper motor neuron lesion are going to undergo atrophy of disuse over time. Yes, sir. Please give me a second, you guys. I will be back shortly. All right, I'm back. Where did we stop? Sorry for that, you guys. I had to help get some things intact, okay? But we are back. Where did we stop? We're talking about lower motor neuron lesions. Okay, lower motor neuron lesions. So they are going to have hypotonia, weakness, atrophy, areflexia, fasciculations, and flaccid paralysis. Okay, and flaccid paralysis. All of these are going to be components you see in lower motor neuron lesion. Remember that. Something I forgot to mention earlier. We talked about upper motor neuron lesions. I told you that the corticospinal tract does not mature until about 2.5 years of age. You remember that? It does not mature until around 2.5 years of age. What does that mean? It means that newborns, people 1 year old, very little children or infants are going to have positive Babinski sign, and this is going to be normal in them. Okay, so when you see positive Babinski sign in a child, a very young child, an infant, this is completely normal. That is that for your upper motor neuron and lower motor neuron lesions. Do you guys have any questions? Do you guys have any questions? If you don't have any questions, we are going to start looking at some very important spinal lesions they want you to know on your exams. We'll look at spinal cord lesions. Because on your exam, when there is injury to the spinal cord, it does not occur in isolation, right? Injury to the spinal cord do not occur in isolation. You're going to damage multiple tracts at the same time, or you're going to damage multiple parts of the spinal cord at the same time. And this is what your exam is going to be testing you on. The first one we are going to be considering is going to be spinal muscular atrophy. Spinal muscular atrophy. In spinal muscular atrophy, you are damaging the anterior horn of the spinal cord. You're damaging the anterior horn of the spinal cord. Okay, this condition is spinal muscular atrophy. Spinal muscular atrophy. You're damaging the anterior horn of the spinal cord, except in this case nobody actually damaged it. This is actually congenital damage. I don't know if we can even call it a damage, or we should call it a degeneration. Okay, a congenital degeneration of the anterior horn of your spinal cord. Congenital degeneration of the anterior horn of your spinal cord. Why will somebody have a congenital degeneration, and what do they want you to remember on your exam? On your exam, they want you to remember two things. First of all, that this is autosomal recessive inheritance. This was an NBME question somewhere. This is autosomal recessive inheritance. The gene is the SMN1 gene. These are the details they would want you to remember. I've seen them test all of these parts. It's a mutation in SMN1 gene. It is an autosomal recessive inheritance. Now, there are other variants of this disease. We have mutation in SMN2 gene, for example, but SMN1 gene is more common on your exam. And SMN1 gene specifically, as a subset of spinal muscular atrophy, is known as Wednick-Hoffmann disease. is known as Wednig-Hoffmann disease. The SMN1 gene mutation, that variant of spinal muscular atrophy, is called Wednig-Hoffmann disease. You want to remember that. Now, the next question is, what do you expect the vignette to look like? How will patients with spinal muscular atrophy present? Well, you're damaging the anterior horn of the spinal cord. If you damage the anterior horn of the spinal cord, what do you have? Lower motor neuron signs. You're going to have lower motor neuron signs. So there'll be weakness, right? Complete weakness in these babies. These people are going to be very little babies. There'll be complete weakness in these babies. These babies are often described as floppy babies. They are often described as having floppy, almost like floppy baby syndrome, but I don't want to say floppy baby syndrome because I'm sure you've learned floppy baby syndrome for something else. Do you remember what infection or what toxicity we associated with floppy baby syndrome? I hope you said botulinum toxin. Okay, botulinum toxin was associated with floppy baby syndrome. So I would not like to use the same phrase, floppy baby syndrome, here, but these people are also described as floppy babies. They will have weakness, they will have areflexia, they will have hypotonia, they will have fasciculations. You want to remember all of those. The second thing we'll consider is amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis. In ALS, you damage the lower motor neuron or the anterior horn of your spinal cord, and you also damage the corticospinal tract. This is amyotrophic lateral sclerosis, ALS. It's also called Lou Gehrig's disease. What do they want you to remember on your exam about ALS? They want you to remember that patients with ALS have pure motor signs. Patients with ALS will have pure motor signs. They want you to remember that they have no sensory signs. This may be the most important thing you remember about Lou Gehrig's disease. So if I give you a vignette and I give you a patient with weakness here and weakness there in various parts of the body, and I tell you they have no sensory signs, or you go through that entire vignette and the patient has no sensory symptoms or no sensory losses, then you are probably looking at a patient with amyotrophic, not trophic. You're looking at a patient with amyotrophic lateral sclerosis. Okay, ALS. Pure motor signs, no sensory signs. The other thing is they have no bladder involvement. They have no bladder involvement. One of the things you want to know also with amyotrophic lateral sclerosis, ALS, is that when we talk about the pure motor signs, ALS affects upper motor neuron. It affects the upper motor neuron. It affects the lower motor neuron. So you're going to have upper motor neuron signs. You're going to have lower motor neuron signs. You're also going to have corticobulbar sign. You're also going to have corticobulbar sign. You want to remember that. So upper motor neuron sign, lower motor neuron sign, and corticobulbar sign. When we say corticobulbar sign, what do we mean? Your corticobulbar tract is the are the tracts that supply your upper motor, not your upper motor neuron, your cranial nerves. Okay, your corticobulbar tract is the tract that supply the upper, I keep saying upper motor neuron, okay, call them upper motor neuron of your cranial nerve. Okay, so the corticobulbar tracts are like the upper motor neuron of the cranial nerve. It's stuck in my head in a particular way, so I have to bring it out like that. It's the upper motor neuron of your cranial nerve. So what does that mean? When you damage these upper motor neuron of your cranial nerves, we are going to have some cranial nerve signs. Things like dysarthria. If you remember, your vagus nerve and speech, dysphagia. Again, your vagus nerve, difficulty swallowing. We may get respiratory failure. We may get respiratory failure, for example. What else? You may have emotional lability also in these patients. Again, notice that with all of these things happening, there is no sensory deficit. No sensory deficit. How do you treat patients with Lou Gehrig's disease? You treat them with riluzole. We treat Lou Gehrig's disease with riluzole. I don't know how you pronounce this. Some persons say riluzole, we say riluzole, the same thing. We treat ALS with riluzole. That is important. You want to remember that. I've seen a question also once where they ask for the specific gene that is mutated or defective in ALS. I think I've seen something like that. You want to remember that ALS is as a result of mutation to superoxide dismutase. It's not the most important thing, but I've seen them ask about this one time. Superoxide dismutase 1. I think of it as SOD1 gene. Okay? It's a mutation in superoxide dismutase. You want to remember that. The third spinal cord deficit we are going to consider will be your anterior cord syndrome. Anterior cord syndrome. So let's assume that this is the spinal cord, for example. Okay? This is the spinal cord. You want to know a little bit about the blood supply to the spinal cord. The anterior portion of the spinal cord is supplied by one blood vessel. We have one pretty impressive blood vessel supplying more than half, about 2/3 of your spinal cord. Okay? One single blood vessel supplying the anterior 2/3 of the spinal cord. This is the anterior spinal artery. The anterior spinal artery. The anterior spinal artery is a branch of your vertebral artery, usually. The anterior spinal artery supplies the anterior 2/3 of the spinal cord. You want to remember that. On the other hand, we have two on the back. Two posterior spinal arteries. Two posterior spinal arteries supplying the posterior 1/3 of the spinal cord. And in addition to the fact that there are two of them, these two posterior spinal arteries have collateral supply. So imagine what it would take for someone to have a posterior cord syndrome, right? It's almost impossible. They have collateral supply from the artery of Adam-Kiewicz. I hope I have spelled Adam-Kiewicz correctly. They have collateral supply from the artery of Adam-Kiewicz. What does this mean? The implication, therefore, is that you are hardly going to have posterior cord syndrome, but we can easily have anterior cord syndrome in persons with atherosclerosis, for example. So one of the main risk factors for anterior cord syndrome is going to be atherosclerosis. We may have an atheromatous plaque, for example, get into the anterior spinal artery, occlude that artery, and cause ischemia to the anterior two-thirds of the spinal cord. You want to remember that. In anterior spinal artery, syndrome or anterior cord syndrome, which is what we get when you damage the anterior spinal artery or occlude the anterior spinal artery. In anterior cord syndrome, you have damage to the anterior two-thirds of the spinal cord, like we mentioned. But notice that it spares the dorsal column. It spares the dorsal column. So how do you think these patients may present? How do you think these patients may present? Somewhere here, we had the anterior spinothalamic tract. We had the lateral spinothalamic tract. We had the posterior spinocerebellar tract. Somewhere here. The posterior spinocerebellar tract. We had the anterior spinocerebellar tract. We had the corticospinal tract on both sides. The corticospinal tract. You will notice that all of these tracts have been affected. All these tracts have been affected in this anterior cord syndrome. So how will a patient with anterior cord syndrome present? Becomes the question we need to answer. How will a patient with anterior cord syndrome present? You can start walking through each of the tracts that will be affected. You say, okay, the corticospinal tract is involved. Right? The corticospinal tract is involved. So we are going to have upper motor neuron signs bilaterally. Usually. Do you see that? Upper motor neuron deficits bilaterally. All these deficits will be below the lesion. Very important. We are also going to have lower motor neuron signs bilaterally. What about your spinothalamic tract? The spinothalamic tract is going to be damaged. So we are going to have loss of pain and temperature bilaterally as well. Loss of crude touch and pressure as well. All of these symptoms will be present bilaterally in anterior cord syndrome. The next thing we are going to look at is syringomyelia. Syringomyelia. We have a spinal cord like that. What happens in syringomyelia? We have the central cord canal right there, or the spinal canal right there. In syringomyelia, you have the development of a syrinx within the spinal canal. The development of a syrinx within the spinal canal. That is what happens in syringomyelia. We have a syrinx develop and begin to expand within the spinal canal, like that. Look at that. As it grows bigger and bigger, it begins to affect whatever nerves are in its vicinity. As it grows bigger and bigger, it begins to affect whatever nerve is in its vicinity. If you remember, we mentioned that this corticospinal tract, did I say corticospinal? The spinothalamic tract came into the spinal cord and crossed over to the anterior and lateral parts of the spinal cord. So when you have a syrinx here, when you have a syrinx, this guy growing within the spinal cord, when you have this syrinx growing, you can imagine how it's going to compress on your spinothalamic tract, right? A syrinx growing within the spinal cord, within the spinal canal, and expanding. You can imagine that it will first affect your spinothalamic tract as they cross over bilaterally. So how do you expect a patient with syringomyelia to present? How do you expect a patient with syringomyelia to present? They have loss of pain and temperature bilaterally. They have loss of pain and temperature bilaterally because you're going to be damaging the spinothalamic tract coming from both sides and crossing over like that. You're going to be damaging both of those spinothalamic tracts. So these patients will present with bilateral loss of pain and temperature. Now, most of the time, this syrinx will be located around the cervical spinal cord. The syrinx will often be located around the cervical spinal cord. If you have a syrinx located around the cervical spinal cord, it's up there, right? It's going to cause loss of temperature all over the body, especially your upper limb, your lower limb. We often describe this as cape-like distribution. Cape-like distribution, meaning it's like you wear a coat, a cape. It covers from your shoulder down. That kind of thing is how people with syringomyelia will experience loss of pain and temperature. How do you know a person has syringomyelia on your exam? They're going to give you a vignette of a patient that burns themselves over and over and over again. A patient with recurrent burn injuries. They don't feel pain when they get burnt. They can put their hands on the stove and roast. Okay? Their hands could roast, and maybe if they don't smell their hands smelling like goat's meat or something, they don't even notice that they are burning up. That is how syringomyelia presents. Bilateral loss of pain and temperature in cape-like distribution. You want to remember that. Now that reminds me, do you remember any conditions that are associated with syringomyelia? Do you remember any conditions in the brain stem, closer to the brain stem, associated with syringomyelia? I hope you said anode-Chiari malformation. You want to remember that syringomyelia is associated with anode-Chiari malformation. Specifically, anode-Chiari 1 malformation. Syringomyelia is associated with Chiari 1 malformation. Now, of course, if nothing is done and the syrinx keeps growing bigger and bigger and bigger, eventually this syrinx will affect other tracts, right? My Siri is hearing me talk to it, but I'm not talking to it. But eventually, the syrinx is going to affect other tracts. However, on your exam, most of the vignettes that are going to be given you are going to be vignettes where the patient is just going to have loss of pain and temperature. Okay? The patient is going to have loss of pain and temperature. You want to remember that. Whenever I say syrinx, I activate my Siri here and she wants to talk to me, which is kind of cute, but I'm not ready for that right now. All right, next we are going to look at tabes dorsalis. Tabes dorsalis. I think we are going to do a few questions related to spinal cord injuries in our next session. Okay. Next we look at tabes dorsalis. What happens in tabes dorsalis? What happens in tabes dorsalis? There is destruction of the dorsal horn. That's how I want you to remember it. In tabes dorsalis, there is destruction of the dorsal horn. That part of the spinal cord right there. What do you notice? This was where all those nerves entered the spinal cord. This was where all of your nerves entered the spinal cord, right? At the dorsal horn of the spinal cord. So when you damage the dorsal horn of the spinal cord, what do you think is going to happen? All your sensory nerves that were entering the spinal cord will be damaged. So in tabes dorsalis, there will be a loss of sensory function. You want to note, of course, that your dorsal column will be affected. Your fasciculus gracilis, fasciculus cuneatus, they all went through the dorsal horn of the spinal cord. Notice that you did not damage the ventral horn. We did not damage the ventral horn. Your spinocerebellar tract is affected. So, what are we saying here? Spinothalamic tract is affected. Is affected. Your dorsal column is affected. Is affected. Your spinocerebellar tract is also affected. All of these ascending tracts or sensory tracts are basically going to be affected. So how do we expect this patient to present? They'll present with sensory ataxia because of spinocerebellar tract involvement. They'll present with sensory ataxia. Sometimes they'll describe it as progressive sensory ataxia. Progressive sensory ataxia. Because of dorsal column involvement, you will have loss of vibration, loss of proprioception, stereognosis, loss of two-point discrimination, for example. All of these loss of function will be predominant in these patients. Now, the next question you want to ask yourself is, what causes tabes dorsalis? What causes tabes dorsalis? Tabes dorsalis is seen in tertiary syphilis. Tabes dorsalis. Wow, tertiary syphilisis. Look at me. Is seen in tertiary syphilis. Okay, tabes dorsalis is seen in tertiary syphilis. So people with tabes dorsalis may have other symptoms of tertiary syphilis. You see, they may have other symptoms of tertiary syphilis. Can you remember any other symptoms of tertiary syphilis? Your Robertson pupil, for example. Robertson pupil will be one of them, right? Robertson pupil. You want to remember that. They may have some pains, joint pain, shooting pain. There's a lot of features that they will describe to you related to tertiary syphilis. They may also tell you that PR is positive, or some form of VDRL tests, some form of syphilis test may be positive in these patients. You want to absolutely remember that. The last thing I would mention here before we finish, and then we'll come back to do questions related to this in the next session, is B12 deficiency. B12 deficiency. You would remember that B12 deficiency causes subacute combined degeneration of the spinal cord. subacute combined degeneration of the spinal cord is often seen in B12 deficiency. So what exactly is subacute combined degeneration of the spinal cord? Subacute combined degeneration of the spinal cord is damage to specific parts of the spinal cord. The most important ones are your corticospinal tract and your dorsal column. The corticospinal tract and the dorsal column. This is what subacute combined degeneration of the spinal cord is. Why does that happen? In B12 deficiency, if you remember, just B12 and B9 had elevated homocysteine. You remember that from biochemistry? But B12 also had elevated methylmalonic acid. So B12 deficiency had increased methylmalonic acid. And what happens? Methylmalonic acid seeps into the spinal cord and resulted in damage to the dorsal column and corticospinal tract predominantly. So it is the fault of methylmalonic acid technically in B12 deficiency. This is what we call subacute combined degeneration of the spinal cord. The spinocerebellar tracts are not spared. Before I forget to leave them out, your spinocerebellar tracts are also damaged in this condition, right? So there are three of them: the dorsal column, the corticospinal tract, the spinocerebellar tract. You'll notice that we have a mix again of sensory deficits and motor deficits. This will usually be in the setting of B12 deficiency. So you expect this patient, in addition to having symptoms related to the spinal cord, related to the dorsal column, the corticospinal tract, you expect them to also have megaloblastic anemia with hypersegmented neutrophils. You expect them to have megaloblastic anemia with hypersegmented neutrophils, right? In addition to that, they're going to have symptoms related to the tracts that are damaged here. So dorsal column, loss of vibration, loss of proprioception, maybe positive Romberg sign. They may have positive Babinski because of spinothalamic tract involvement. They may have ataxia because of spinocerebellar tract involvement. The point is, you just want to know whenever there is this symptom, this is the tract that is damaged. Whenever there is that symptom, that is the tract that is damaged. If you can remember all of those, you'll be able to interpret many times as they give you a vignette. Remember the principle, of course, you're interpreting line by line. For every symptom they give you in the vignette, you want to map it. If I see this symptom, this is the problem, you want to know what specific tract is damaged to produce that specific symptom. The other thing you want to answer is the tract ipsilateral or contralateral? Like we mentioned before, spinothalamic tract lesions are always contralateral. Spinothalamic tract lesions are always contralateral. Your dorsal column tract lesions are ipsilateral within the spinal cord, but contralateral above the medulla. So once they go above the spinal cord, they are contralateral. When we start doing some questions related to all of these things, we are going to look at how to more adequately localize lesions, how to identify problems, and know exactly where the injuries are. Until next time, I'm going to see you guys soon. If you are new here, please subscribe to the channel, turn on notifications so you're going to receive a notification the next time I go live. We are going to jump in much faster, and we are going to be doing some questions and answering questions related to neuro, of course, and answering every question you may have related to the USMLE. Until next time, I'll see you guys